to log on. Actually, we can just start with some updates. I missed the last one, so thanks for filling in for me. It's kind of how the summer goes with people in and out on different alternating weeks. I just want to start and once again thank many of you who were involved in our MSTAR program, whether it was in the as a mentor or as a discussant or just kind of showing up and seeing their presentations last week on Monday. I know it's a lot of work when you take someone on and you kind of shepherd them through the project, and it was a quick program. We'll see if we can do something about that. It's now funded by the NIH, so it's strictly like an 8-week program, where when it was foundation funded through the Hartford Foundation, we stretched it to like 10 weeks. So it was a little more condensed than it usually is, but I think if you were there for the final presentations, it really was amazing. So I appreciate everyone's efforts, and anyone also who stepped in and helped. I know Crystal stepped in and helped one of the students with his SAS work and things like that. So very much appreciate it. It was really fun. And the application will start again, probably in November, I think. So think of any projects that you can put on hold until then that someone can do. It's always a great opportunity. So, hey, Sean. I was just thanking everyone for their MSTAR participation, because it was final presentations were great. So why don't we see, does anybody have any updates or announcements? I think the AHPM call is already done. Is that right? It was the week I was on vacation. So that one is done. Is there any other that people know of that are coming up that people are aiming for? We should put on the radar. Okay. No announcements. Okay. All right. As they come up, we'll certainly let everybody know. So this week, if there's not any other updates that we need to talk about, Emily, anything going on at the VA that's new that hasn't been discussed here?
I don't think there's anything brand new. I think we had mentioned at some of the previous meetings that we're trying to replicate the WIP process and some of that within the VA GREC as well. So we're planning another fall writing intensive, which went really well the first time we did it. And we're also instituting some other kind of productivity breaks and accountability measures to help us all, get the work done and get push some of our writing and other projects along. So we'll keep folks updated on that. And you're of course welcome to join in if you need like a writing power hour or any other productivity tips that we can share. And we'll let you know how they're working for us and what seems to work.
People have done various experiments with this, so I'm interested to hear how it goes and what people have found helpful. So thanks for doing that. Anyone on who hasn't been, who's new, who hasn't been welcomed yet? I see Mohammed there, but I think we introduced you at an earlier one because you've been here for a little bit now, so welcome. Any others?
Hi, my name is Wing-Yun Mack. I am with the New Jewish Home Research Institute on Aging, and also recently got appointed over at the Icahn Medical School, School of Medicine in the Geriatrics and Palliative Medicine department. And we thought it might be a good idea to join this group and see what everybody's doing.
Great, welcome. Yeah, we're glad to have you. So we do various range of work in progress to updates to other things. So if you'd like to get on the schedule, just shoot us an email. Otherwise, you'll eventually be assigned a slot, perhaps. But it's all very welcoming. We'd like to hear what you're working on, etc. So welcome.
Awesome, thank you.
All right, so we have Claire on deck for today. So if you want to go ahead, take over.
Great. Yes. And so it seems like I have the full time. So I am going to start with some presenting some work sort of updates from existing work that I've been doing. And then I would really love feedback on an R01 proposal that I'm planning for October submission. So I was thinking this was nice timing for feedback. Okay, can everyone see my screen?
Yes.
Right. So as you may have guessed, my work is about Medicare Advantage, as it has been for the last while. And as I said today, I'd like to talk a little bit about some updates on projects from the last year and what I've learned. Oop, I think the screen has not changed. What I've learned, and particularly around hospice enrollment and this idea around heterogeneity across MA plan types, which I think is the direction that I'm most interested in going in. And then talk a little bit about this R01 proposal that I'm trying to submit in October. It's to the NIA, and it's a specific call for proposals that look at health policy issues in older adults with dementia. So my overall research aim is really to think about how Medicare Advantage plans shape the care of older adults with serious illness, with several areas of particular emphasis, because MA is such a growing area of complexity and research. So first of all, focusing on home-based care in Medicare, and as I'll talk about increasingly in Medicaid, focusing on care delivery at the end of life, again, because I'm particularly interested in this serious illness population who have a very high risk of mortality, and focusing on inequities and outcomes. A lot of research in the last few years, and I'll show you some of this, has shown that MA is really disproportionately growing among Black and Hispanic older adults. And also is incredibly regional in terms of the way that MA plans operate and the effects they seem to have. So I'm very interested in diving into that. And then finally, I'm really interested in fundamentally exploring variation in plan structures. And the reason is, in part, my thinking is, this simple question of MA versus DM. First of all, it doesn't really capture the variation that exists in the world of insurance these days and that most of our older adults face. And also, MA is not going away. And so understanding which MA plans are performing better for our populations may practically point us in the direction of what kinds of regulation are helpful, what kinds of quality measurement is helpful to incentivize MA plans, really providing the best care possible. So what is new since I think the last time I talked about Medicare Advantage in a WIP? The first thing is MA in the last 2 years has grown actually far more rapidly than it was anticipated. So we used to say that by 2030, MA would become the dominant form of Medicare. Now we think that will happen in 2025. The testing of a hospice carve-in into Medicare Advantage, which I think I presented some data on in a prior WIP, has continued. The carve-in model is now in year 2. There are mixed reports on the carve-in. It's not a broadly available broad carve-in yet, but that is continuing. And yet for another year, I think the 3rd year in a row now, MedPAC has yet again determined in their annual report to Congress on Medicare services that we still have insufficient data to assess quality in Medicare Advantage. And if anything, the picture is growing more blurry. And in part, there was this great health affairs series on Medicare Advantage and payment in MA, and in part the sort of MA diagnosis inflation game and some of the incentives that exist that both potentially lead to overpayment in MA and make it really, really hard to evaluate quality. And so first, I'm just going to walk through some of the projects that I've been working on that have really, for me, been very helpful to think about what my next steps are. So first, these first 2 projects addressed Medicare Advantage and hospice use. And this was work I did in collaboration with a team, mainly at Brown. So it has long been known that hospice enrollment in Medicare Advantage is higher. That's the purple dotted line than hospice enrollment among decedents in traditional Medicare. That's the red dotted line. Over time, that gap has narrowed, but that difference has persisted. And yet, besides whether or not people are in hospice, we really wanted to know, well, what about the overall pathway to hospice? Is it that, a lot of Joan Tino's work has shown that, often people are sort of put through the ringer in terms of ICU stays and hospital stays, and then they finally end up in hospice? Is this pathway that people take to enroll in hospice different in Medicare Advantage versus traditional Medicare? So we've done some prior work looking at the pathway to hospice. This paper came out in JAGS a few weeks ago, looking at the site of care prior to hospice enrollment, and defining that as either the hospital, the community. For this graph in orange, it's the community without home health versus from home health in gray, or from a skilled nursing facility or nursing home. And you can see that this really varies by diagnosis. It also varies tremendously by region, where you can see this is the proportion who are admitted to hospice only from a hospital stay. And you can see that's nearly the majority in the blue states, the darkest blue states. That's nearly the majority of hospice users, while you have many more people enrolling in hospice from community settings in the light green region. So we see this regional difference in hospice use. But we wanted to know, is this different in Medicare Advantage compared to traditional Medicare? And looking at this site of care in the at the end of life. And I wrote last month, but it's not last month, it's last 90 days of life. So for this study, we used Medicare claims from multiple years. The reason why we selected these years is because we wanted to see trends over time, but our data modeling got fairly unruly when we tried to model it with every single year, to the point where models were taking like weeks to run. But with this sample from the years I list, we were able to develop a cohort of decedents who are enrolled in hospice in the last 90 days of life, about 7.5 million older adults. And we were able to use this novel approach to identify the site of care prior to hospice enrollment. There were a few we couldn't identify the site of care for, but we could for the majority, and I'll tell you more about what that means. And then we didn't look at the long stay people, which we know long stay people who are in hospice for greater than 90 days are a very different population. And we also wanted to look at really these sort of acute end of life changes. And then we looked at multiple sensitivity tests, narrowing our cohorts to different populations, because one challenge that persists in MA research is that people in MA vary from people in traditional Medicare. Traditionally, people in Medicare Advantage are healthier, and we know that from studies of decedents, their demographics, where they live in the country, all of that varies substantially. So we limited to these different subpopulations to try and reduce this variation in the population that we're comparing. So location of care prior to hospice, this has been sort of one of the measurement development areas I've been looking at, of sort of what can we see in our claims data in terms of Medicare Advantage. So as you all likely know, we don't have full claims data the way we do in fee-for-service, but we can, using these creative approaches, sort of look around the edges of what's happening in Medicare Advantage. So for example, we can see hospital use and nursing home use through the MedPAR file that captures, I think, 92% of decedents of beneficiaries in Medicare Advantage. We can see home health through OASIS, and we can see hospice use very reliably through the hospice files, because of course hospice is not part of Medicare Advantage. So we defined the location of care prior to hospice enrollment as either hospital, nursing home, and then home with or without home health. We did have some caveats, because you can imagine if someone is discharged from the hospital, it might take 2 or 3 days before, as we've experienced recently in COVID, before the hospice agency can send a nurse into their home to officially admit them into hospice. But clearly that process was initiated in the hospital setting. So we use some caveat in these definitions to account for that lag that may occur. from where a hospice referral was initiated to where the patient actually was the moment the hospice nurse came and enrolled them. And then for most of our modeling, we simplified this to be hospice enrollment from the community versus all other settings. And then we looked at Medicare Advantage as the main predictor variable of pathway. And we looked at this multiple ways. We looked at enrollment in Medicare Advantage in the last month of life, but we also looked at enrollment in Medicare Advantage 1 year prior to death. And the reason for this is that we know that people leave MA plans at higher rates at the end of life. And so we wanted to see if we are seeing differences, is this driven by different rates of people leaving MA? We also, because there's increasing nuance in the traditional Medicare side in terms of other value-based models, separately considered ACO enrollment in some sensitivity analyses. And so for 2016 and 2018 looked at ACO enrollment. And we included a whole slew of covariates. You can see in the top bullet in our primary cohort, one of our challenges in claims data is we really don't have the sort of rich function health social data that I'm used to using in NHATS and HRS and some of our surveys. So we did what we could do there. But then in one of our cohorts that limited to those with a nursing facility stay where we had access to the MDS, that allowed us to use a much richer set of covariates to capture illness. And then in terms of modeling, we used a logistic regression model that predicted community hospice enrollment versus all other pathways of hospice enrollment. Our main independent variable was Medicare Advantage versus traditional Medicare. And we modeled county level fixed effects. So in other words, this analysis is within counties. And the reason that's important is because, as I told you, a lot of Medicare Advantage growth is so regional. We didn't know, like, if you're looking at all MA versus TM, is that just about places where MA is growing the fastest? The West Coast, for example. And then we adjusted for the covariates I previously described. And then I'm not going to go into detail on this, but we looked at a bunch of other alternative models. So you can see here, this is our raw data, and this is the proportion of people in hospice who were enrolling in hospice from the community. As you can see here, we know that hospice enrollment, we found and already knew that hospice enrollment is higher in MA. We also found that in our unadjusted data, people were more likely to enroll in hospice from the community in MA. So about 10% higher in the initial study period, narrowing slightly by the end. And as you can see here, there was really no difference between older adults in traditional Medicare who were in ACOs versus not. So we didn't focus on the ACO comparison. And then this is the summary results of all of our sensitivity analyses. The main number to focus on here is this overall result, where essentially we found a little over 8% higher community enrollment in Medicare Advantage versus traditional Medicare. And this is adjusting for that county level fixed effects. Here, this is just one of our hypotheses, was that this was about MA penetration, regional penetration, which we didn't find a significant linear trend for. And this is just, again, our primary model and all these other sort of cohorts we looked at to try and make sure this wasn't due to population differences in those in Medicare Advantage, finding much greater enrollment in hospice from the community in Medicare Advantage. So as I said, our conclusion is that hospice enrollees in MA are more likely to enroll in hospice from the community versus other settings than compared to those in traditional Medicare. We didn't really see an effect of ACOs. And, we really didn't see this county level difference that we thought we would see, but we did see that this association remained in all sensitivity tests. And I think highlighting the last bullet, this really raised more questions than it answered of, okay, MA plans are enrolling more people in hospice, they're enrolling more people from the community, but who exactly is being enrolled and what does that mean for quality? And so I'm actually going to skip this and talk about project 3 next. So I should have listed this in different orders, but this really led to this next smaller project that I've been working on with a team here. Lisa in particular, Lihua advising on methods, Melissa and Karen using MCBS data, sort of diving into more about these differences of how Medicare Advantage is shaping care. So for background, as I showed you, more people in MA enroll in hospice compared to traditional Medicare. However, we know that the baseline population in Medicare Advantage is very different than that in traditional Medicare. What we don't know is whether this increased hospice enrollment varies across patient groups, or is it concentrated in certain groups? And so we wondered if it might be useful to pose the question of the counterfactual. So that is saying, if everyone in traditional Medicare were in Medicare Advantage, what would hospice enrollment look like? Overall, how would it look? And among different subgroups of patients by their characteristics, how would hospice enrollment look? For this study, we used MCBS from 2010 to 2018, and we created a counterfactual model. So first, we identified the odds of hospice enrollment adjusted by all these individual characteristics for sociodemographics, living setting, and health, among those in MA. And then we applied those odds of hospice enrollment to the population in TM. So this allows us to identify what the observed rate of hospice enrollment is in the traditional Medicare population and the counterfactual rate of hospice enrollment. In other words, if this population had the same rate of hospice use as the equivalent population did in Medicare Advantage. That allows us to see both what the overall effect of MA is on hospice use and how it varies across these characteristics. So here are some preliminary results. We found, like other studies, that rates of hospice use were higher in Medicare Advantage in the yellow bar compared to traditional Medicare in the blue bar. In the raw data, we didn't find as dramatic of a difference as other studies have found. Part of that is because of sample size, but we still clearly found higher use of hospice in MA. And this is, I'll walk through what this means, this very, very busy graph, but this is applying our counterfactual model. So this shows for each of these population subgroups, two rates of hospice enrollment. In the solid bar, that's the observed rate of hospice use for this population in traditional Medicare. In the dashed bars, that is the counterfactual hospice enrollment, or from our model, what we would predict hospice enrollment would be if they were in Medicare Advantage instead. And the first set of bars here, you can see in the entire population, you can see that this is, again, adjusting for all these covariates, that we would predict hospice enrollment would be about 8 points higher in the entire population of traditional Medicare if they were enrolled in Medicare Advantage. But as you can see, both the overall heights and the discrepancy between the observed and the counterfactual hospice enrollment vary considerably by demographic groups. For ease of interpreting this, I'm going to show you another graph that just looks at the difference between these two bars. Oops. So now this graph shows how much higher hospice use is in the counterfactual versus the observed models. So how much does MA enrollment increase hospice use? The black bar is the overall population, and I extended the line of where the black bar is across the graph just for ease of interpretation. So any population subgroups that are falling above the black bar are populations where hospice use is far higher in MA in this counterfactual model than it was observed to be in traditional Medicare, even if you control for these characteristics. Bars that are positive, so above 0, but below the black line, are where we're still seeing higher hospice use in this counterfactual model than we observe in traditional Medicare. And yet the increase in these groups is actually not as much as the increase in the overall population. So we could say that if these people were enrolled in MA, they might enroll in hospice at higher levels, but hospice use isn't really concentrated in these populations. And then at any population subgroups that are negative, below 0, that means that hospice use was actually higher in traditional Medicare than if those people were to have been in Medicare Advantage. Does that make sense to people with questions about interpretation of this? This was a new analysis approach to me and our team. So we are working on how to explain this and how to visually display the data. So what you can see here, oh yeah.
Can I just ask a quick question? So these are not all significant differences though, right?
No, I haven't. I actually have to talk to Liwa about how to test significance because I'm comparing the actual versus the predicted. So these are not all significant. Error bars and significance tests coming. So you can think of these as trends for the purposes of where we're at with this analysis. I will also say, okay, how do I word this? I did not include every possible bar of every subgroup. So for example, okay, like with sex, we have female and male here, and both basically the weighted average should equal the black bar, right? So like I'm giving you female and male, I'm giving you race, white and non-white. But across other things, like I'm just showing you dementia, I'm not showing you dementia, non-dementia. And part of that was just like, how do I make this not totally overwhelming to you all and showing every possible demographic group. So I did do a little bit of selecting of what I'm showing you. But clearly from what you can see here, we can see where hospice use is concentrated in Medicare Advantage. And that it's really concentrated in the younger decedent population, those less than 70. Again, I skipped the middle age group. I'm just showing you less than 70 and older than 90. It's concentrated on racial and ethnic minority populations, which is particularly interesting because we know that, as I said, most growth in MA has been among Blacks and Hispanics. It also, from this data, looks like hospice is functioning differently among those populations. It is not at all in the nursing home population, as you see here, and growth is really concentrated in those in either independent housing or residential housing, like assisted living or group homes. And it's highly regional. Like as you see here in the Northeast, there's actually, this pattern does not exist in the Northeast from this data at least. We're seeing that hospice use in TM is actually higher in reality than it would be in the counterfactual in the Northeast. It's really concentrated in the South and West, which I think gets to some of these regional issues. And it's also concentrated in the cancer population, which mirrors some of the results we found in the Pathway project, where we found that, again, a lot of this increase in hospice use in MA is among patients with cancer who are admitted from the outpatient setting, like from their onc clinics. So again, some of this is consistent, some of this is new information or very interesting in terms of racial and ethnic differences in hospice use. So in conclusion, we find, like in other studies, that hospice enrollment is higher in MA. We add to this literature by demonstrating that this higher enrollment is concentrated among certain groups. Decedents from racial and ethnic minority groups, younger decedents, and decedents in non-institutional settings, as well as those with cancer. Notably, hospice enrollment is actually lower in MA than we observe in traditional Medicare among dual eligibles, those in Medicaid and those in the Northeast US. Before I proceed, any questions about that analysis or that work? Okay, jumping in then to the last, I'm actually going to go up to project 2. The last little bit of work that sort of informs where I'm going with this R01, just to sort of set people up. As I said, I've been increasingly interested in variation in MA plans. And so I've been doing this work on looking at dual eligibles and Medicare Advantage and where they are in terms of their insurance coverage to try and set myself up to look at outcomes. And my collaborator is Laura Cohen, who is she was at Brown, now she's at Vanderbilt. She's a health services researcher there. And so Medicare Advantage is increasingly complex in that there are many, many different plans based on the market you're in, typically somewhere in the range of 20 to 50 plans to choose from. But plans also, yes. Oh, is that a question? No. Okay. But plans also vary considerably in their structures. So we've had this sort of small shrinking proportion in orange of employer or union sponsored group plans. In my training in Michigan, I saw a ton of this because there was a lot of people who worked in the auto industries and had really robust MA plan coverage in retirement that were sponsored from their employer, but we are seeing less of that overall. We are seeing overall growth in terms of the blue, which are the MA plans you think of plans that you see advertised, plans if you go to MA Compare that you can sign up for and open enrollment. But we increasingly have these special needs plans, which is about where 15% of MA enrollment. So there are three kinds of special need plans or SNPs. There are dual SNPs, D-SNPs, institutional SNPs that focus on the care of older adults in institutions, I-SNPs, and chronic disease or C-SNPs. Notably, there are only a few chronic diseases that account for C-SNPs. So the most common one, I believe, is for older adults with dialysis, and it makes sense that you might want a particular type of MA plan that really functions around the healthcare needs of older adults with dialysis, and that would have, the appropriate dialysis centers and clinics in their networks. So as you can see here, these D-SNPs, the dual SNPs, have always been the largest type of SNP and are also growing much faster. Dual SNPs come in lots of different flavors. There's fully integrated dual SNPs and highly integrated dual SNPs. And they generally coordinate with state Medicaid plans to various degrees to help provide, in a perfect world, both fully integrated or coordinated Medicaid and Medicare services. So why do we care about this and where people are in terms of their insurance coverage who are duals, who are in Medicaid? So D-SNPs are structured very differently than other SNPs and other MA plans. They have some extra regulatory flexibility to provide non-medical supports. And so increasingly, there's actually this whole market of specialized D-SNP plans that incorporate geriatrics and palliative care expertise. And this is seen as a really fruitful area of development of programs to help patients with serious illness. In plans that are fully integrated, there is a potential for an extra plan payment for a frailty adjuster. So if the MA plan enrolls a patient who's deemed to have frailty by an algorithm that I won't go into, they can get additional payment for them. That isn't across all D-SNPs, and all D-SNPs are not offered across all states. It's really state by state what the most integrated level of D-SNP available is, because this is, as you can imagine, coordinated at a state level with a state Medicaid plan. There is the potential that D-SNPs integrate better with state Medicaid programs. However, that is really uncertain in terms of whether that is actually panning out. I think I mentioned later on, the data on quality here is just really mixed. There's actually Congress, there was a MedPAC report that they were required to investigate and specifically assess quality in D-SNPs. And they found really, truly mixed data. There seemed to be less hospitalization, less institutionalization, but a very high level of emergency room visits in D-SNPs, which indicates potentially there are unmet needs at home. And these are plans that are really seen, D-SNPs in general are really seen as cash cows because they pay at such a high level. And in particular, because of this frailty indicator, other mechanisms, there's really the ability for plans to get paid by Medicare much, much more. than other plans do. Again, that could be great if that's filtered to appropriate benefits for people. So then you have people who are duals, but who are in just a bread and butter MA plan, who just, sign up during open enrollment. Maybe they've been in that plan since they enrolled in Medicare. And this is a tricky situation because they have the network limitations and restrictions of Medicare Advantage. They can't go everywhere. And they don't obviously have the cost savings that make Medicare Advantage appealing to many people. Because they're duals, they have Medicaid that can cover services. So this is an interesting population because it really makes you wonder why. Like, why would you choose an MA plan if you're a dual? An MA plan that's not a D-SNP if you're a dual. And then you have duals who are in traditional Medicare. So this is the most flexible type of insurance in terms of you don't have networks, so you can go to any facility, you can see providers, you probably have less prior authorization burden when you need a CAT scan, when you need DME, when you need that long-acting opioid. But although that would be based on Part D plan. But anyway, because they're duals though, they don't have the downside of traditional Medicare that most beneficiaries have, which is cost. So across, for example, outpatient services in traditional Medicare, there's a 20% copay. If you're a dual, Medicaid would help cover that. So this also, being in traditional Medicare, may also be a smart arrangement for someone. But we really know very little, shockingly, despite how big these plans are and how many people are enrolled, on what does enrollment look like across these three types of insurance coverage. So we wanted to look at what are the demographic, health, and functional profiles of duals across Medicare, comparing those in traditional Medicare versus MA non-D-SNP versus D-SNPs. We used NHATS, and this is older data. We now have data that goes through 2018, 2018. And we identified the Medicare plan type in the MBSF file and linked that to publicly available data on plan characteristics, looking at what plan people were in the month of NHATS survey, since people can switch throughout the year. And in particular, duals have special flexibility to switch. And then we looked at lots of different sociodemographic measures. Harry's asking, do you know what proportion of the non-D-SNPs come into Medicaid sometime after enrolling in MA versus the other way around? Yeah, we can certainly look at that. We haven't looked at that yet, but I would also assume most of these people were in MA and then became duals. That is what I would imagine too. But that's a great point. We could certainly look at when they enrolled. Okay, so here's the bottom line, just to show you. I'm not going to go through all this because I want to get to the R01 stuff, but just to show you, we found really, really striking differences in these populations. So for example, looking at race and ethnicity, we've known for a long time that Black and Hispanic older adults, as I said, are more likely to enroll in Medicare Advantage, and a lot of MA growth is in this population. We found that particularly in D-SNPs, 43.4% of people in our D-SNP cohort were Hispanic or Latino. It was half of that who are not in D-SNPs or in traditional Medicare. So just again, these really notable differences in demographics. In addition, those in D-SNPs were more likely to be younger. And then we looked at a variety of characteristics that we were trying to see, well, where's our sort of frail geriatric population in particular, given the importance of this frailty adjuster in D-SNPs? And the short answer is they're not in D-SNPs. As you can see here, looking at, this was a not significant result, although I think in the updated results, which I'm sorry I did not put, I believe it was significant. Those with dementia are most likely to be in traditional Medicare. They're actually least likely to be in D-SNPs. Similarly, those with stroke, those with multiple other comorbidities, those with hearing or vision impairment were more likely to be in traditional Medicare, less likely to be in D-SNPs. Those with impairment in activities of daily living, greater degree of functional impairment, more likely to be in traditional Medicare, unlikely to be in D-SNPs. And then interestingly, this is something we've sort of ripped off of. So we know from the data what insurance plan people are in. We know if they're in Medicaid or not at the month they did the survey, but NHATS asks them, do you have Medicaid coverage? And we found strikingly different rates of people, whether people knew they had Medicaid. So people in DSNPs had the highest rate of knowing that had Medicaid, which might make sense if they're sort of enrolling in this plan that clearly particularly caters to duals. Those in MA, not in DSNP, which is I tried to set you up for is potentially the worst arrangement for them, really had the lowest rates, over 20 percentage points lower rate of knowing their duals. Which really indicates maybe they sort of got grandfathered in to, or they stayed in Medicaid and stayed in their same Medicare Advantage plan, but they clearly didn't know that they had other options and the nuance of their options if they didn't even know they had Medicaid. So in conclusions, duals and DSNP plans, they're younger, they're more likely to be Black or Hispanic or Latino, they're less likely to have dementia or ADL impairment, which doesn't really align with some of the policy structures around duals and DSNPs, like the frailty adjuster, and the kinds of policies that we would attract this frail older adult population. We also wondered about racial differences and whether these differences in plan enrollments lead to disparities in care outcomes, particularly at the end of life. And we found this really interesting finding about people not knowing they're in Medicaid if they're in MA, not in a DSNP, which is meaningful because they could access a DSNP, which might have these different additional benefits, or they could access traditional Medicare, which would not have the same restrictions in terms of cost sharing or networks. And so it's very unclear what is happening with this group, why they're making these choices, but it does appear that information gaps are a major part of this. And Melissa, yeah, we do. I did not show them here, and there are regional differences in as you would expect, as there are in Medicare Advantage. There are regional differences in where people are too. But yes, I just did not show them here. We unfortunately only have, because this is NHATS, one of the disadvantages is we only have the very broad, like Northeast, East, West. We don't have, like, what I think is more relevant is sort of the county level differences in terms of where plans are offered, which is one thing I want to focus on in the next step, is really looking at as granular as the county level. Okay, so in the last few minutes, I want to talk about this proposed R01 that I'm thinking about. So I guess first, just to say, I have some next steps that are ongoing. I have a dementia supplement on my Beeson Award to use a 100% Medicare claims sample to assess home health and hospice delivery patterns to older adults with and without dementia at the end of life, that focuses on the differences across MA plans. So looks at differences in SNPs, and particularly create this new variable looking at plans with a high proportion of decedents with dementia, and then thinking that those plans might tailor services better to older adults with dementia. Where, yeah, Bevan, thank you. We're right where plans are offered, but where they're targeted. Yes, I think the targeting and where growth is happening is a really important factor here. And so this dementia supplement should hopefully get me the data to start looking with some nuance at region, at the county level, as well as heterogeneity in plan types, but focusing just on the end of life, focusing just on hospice and home health. At the same time, I have a Pepper pilot to interview MA plans and hospices around how MA is shaping hospice care, following up on this quantitative work that I've done in collaboration with Capsy and Emily Gadbois at Brown, looking at what strategies hospices are or MA plans are using. But I'm thinking about this next step in terms of thinking about all sorts of patterns of healthcare use among older adults with dementia. And just some additional background for what I'm thinking about for an R01. So as I said, as I tried to continuously emphasize, I think that MA plan variation is important and increasingly important for duals, which is a substantial population of those with dementia. there's even more complexity in plan choices. And even by states, what dual DSNP plans are available differs a lot. Their structures are different, and there are differences in payment. And it's really important if we understand if things like this frailty adjuster makes a difference in terms of quality of care, because that's the kind of thing. I was in a meeting recently where someone brought up, why do we have these like multiple different kinds of DSNPs? Like, if we're going to make a policy change, why don't we just make it uniformly across duals? But we do have this laboratory to see how these different structures of DSNPs are impacting service use and patterns. And again, we still have really, really limited data on quality and on outcomes. And that is compounded in some part by the policies that drive quality measurement. So for example, quality data in terms of the CAHPS survey that directly surveys people in MA is done at the contract level, not the plan level. So at the contract level, you could have SNPs, HMOs, PPOs, you could have a variety of plan. And in addition, there's recent data coming out that shows that people with dementia are systematically under-surveyed and have a lower response rate in this CAHPS survey. So you really worry, even when patients are directly surveyed about their experience, is our population with serious illness even showing up in these surveys, clearly at a much lower degree. And again, there's been efforts by Congress to look into DSNPs more, and is this payment mechanism really delivering in terms of quality? And there's mixed and somewhat concerning results. And again, looking at plan variation really matters in terms of improving care in MA, and in terms of understanding disparities by race and ethnicity, as well as by region. Okay, so what I'm thinking is an R1 that is a mixed methods approach using both claims data and qualitative research, sort of building off this dementia supplement that I have, and this PEPPER pilot doing some qualitative work with MA plans. So aim 1 is to assess differences in healthcare delivery patterns after incident dementia across TM and Medicare Advantage plans, looking at across plan characteristics and disentangling these regional and racial and ethnic disparities in care. I imagine aim 1 will mainly be focused on the non-dual population because they're so different. Aim 2 will specifically delve into the experience of dual eligibles with dementia, and looking at their experience and disparities in care delivery, thinking both about Medicare services as well as Medicaid, home and community-based services for duals, and again, disentangling regional and racial disparities. And then aim 3 is doing qualitative interviews with MA plans on their strategies to improve home-based care and long-term care integration among older adults with dementia. And again, this is plan submission in October, so we're early enough still that any and all comments people have, even like these are terrible and boring aims and you should scrap them completely, like, you know, like when people present at WIP and it's 2 weeks before and like no one, like you might pick on the grammar, but like you're not gonna, you know, question the premise. Like this is that it's fine to question the premise here, or be like, go in this different direction that I heard you talk about 5 minutes ago. That's way more interesting. So just to set that up. So the next 3 slides are just what my thoughts are, my preliminary thoughts in terms of methods. So aims 1 and 2 are claims, aims 3 qualitative. Aim 1 is again looking at this likely, I'm question mark of whether I exclude duals, but likely non-dual population, looking at differences in healthcare delivery patterns after incident dementia. So the outcome variables, we can't see care patterns in Medicare Advantage perfectly. So I've tried to highlight here the sort of 3 tiers of data I have. The high quality data, I can look really nicely at who's leaving MA and who's switching between MA plans, including like Harriet's question, who's entering DSNPs, who's leaving DSNPs after they have a claims-based diagnosis of dementia. I can do that really well. I can see hospice really well. I can see home health, nursing facility stay, and hospitalization decently. The hospitalization gets a little rougher if I'm comparing MA versus TM, but within MA, I have decent data using claims on hospitalization rates. ED use, you need the outpatient files for, which are encounter file based, and the data there It's not totally complete. There's a high level of missing data, but there's been some great strides in the last year or two on at least defining what contracts have complete data. So you can, for example, look at EDUs and then only look within contracts that are thought to have highly complete data on outpatient services. So there is some work that I could do there with some extra validation. I can also get the MA CAPS data, so directly looking at these survey reports of quality in the MA plan. However, as I told you, we know that the response rate is poor overall, but the response rate is really, really poor among older adults with dementia. So those are sort of not outcomes that I really want to highlight because I think they're sort of shakier ground. The primary predictor variables are MA and traditional Medicare, of course. And this is at the onset of dementia, predominantly to avoid that people may be switching once they get sicker, although it may benefit me to build in a sensitivity analysis with a look back period to account for some switching prior to diagnosis. And then delving into MA plan characteristics. So the type, whether it's a PPO, an HMO, for example, star ratings, the proportion in the MA plan with dementia, and then linking to benefit files to actually get information about benefits in terms of cost sharing, as well as supplementary benefits the plan might offer. Some notes on the analysis. I'm very interested in looking at region in a nuanced way. So looking at county level fixed effects, as well as mixed effects to account for variables at the county level that may be influencing this. I imagine I'm sort of playing around with this for this first aim, excluding duals, for second aim, emphasizing duals. And then looking particularly at disparities by race and ethnicity to stratification, as well as looking at comparator group at people with the onset of dementia, using the same claims files to determine it, who are in traditional Medicare, which helps answer the question, are these differences that we're seeing specific to the population with dementia? Are they minimal in the population with dementia compared to not? So building in and sensitivity analysis comparing to those without dementia. And then aim 2, a lot of this does not change in aim 2, but just to highlight, aim 2 is really also focusing on the dual population, focusing on Medicaid service use, although Medicaid service use, the quality and claims data really varies by state. It depends on what exactly you're looking at, but I will likely end up excluding a whole bunch of states for incomplete data. And then here really focusing on SNPs and specifically on SNP structure and how that's leading to certain different service use patterns and looking at state level differences. And then for qualitative interviews, I envision this as really delving into both from the MA perspective as well as the perspective of stakeholders in these other agencies like home health agencies, hospice, and nursing facilities. You know, what are current strategies that people are using to better improve the care of older adults with dementia. And so interviews focus on MA plan leaders, state Medicaid officials, home health administrators, hospice administrators, and nursing facility administrators. So these will be likely a series of sort of different mini projects within this aim, with the interviews with MA plan leaders focusing on, you know, how relevant is the dementia population to that plan strategy? What is their approach to improving care, barriers to service delivery, and any challenges they have in integrating with LTSS, particularly for DSNPs, who I aim to oversample. And then for these other populations, the question for them really is, and this is similar to the Pepper pilot I'm working on, what is their experience working with MA plans? So getting perspectives from the MA plans themselves, as well as these other organizations that partner with them in caring for this patient population. And then prelim work, I have a variety of projects that will probably inform this proposal or the resubmission of this proposal. But I'm working on finalizing and publishing this DSNP and hospice data. I'm looking with Leon Lay, who's in Michigan, at characteristics of the MA plans that are enrolling older adults with dementia. and working with a group of other researchers on sort of brainstorming a call to action in serious illness in MA, which is very helpful for sort of framing the policy relevance of this. I have the PEPPER pilot, of course, and the dementia supplement. And I think this is a question of incident dementia. So I have a lot of questions about claims-based incident dementia and like, what the heck is this? Right, because showing up in a Medicare claim with dementia is the combination of both clinically having the disease, having an event, a medical event that leads you in the healthcare system, and then being in a healthcare system that is motivated to put that diagnosis on your chart. So diving into that more, and that's work that we're just starting as part of RP1. So I left very, very little time for questions. And I would love feedback. So if people have thoughts to share now, or if they can send me an email, or want to talk offline, or want to collaborate on any part of this, please let me know. But yeah, overall thoughts on the aims.
So this is great, Claire. I think there's so much to unpack in this, and I love the mixed methods approach, because I think that'll be really unique to actually talk to the plan. So I'm glad to see that. I guess my big picture thought as I was trying to pull it all together is back in the beginning, thinking about like what are the incentives of the plans, and so how does that drive their behavior, and then see if it does, you know, because you have so many different patterns, and patterns differ, but it's like, is that what we would expect? Is it like profit? Is it market share? Like have something to kind of guide why that structure is there, and then you see it play out, and then you should or shouldn't think about a policy to address it. You know what I mean? That type of context, I think, would be really helpful to maybe get your arms around it a little more. And maybe even, I don't know if the qualitative in that respect, would it be helpful for that to be first, to talk to them about, you know, how, if you know enough about how they make money in the plans and those kinds of questions, and then see if that leads to some of those differences. So that was kind of one comment. Others?
That is super helpful. Thank you.
The other thought that I have is that kind of thinking about what in CMS that they actually look at some, perhaps not in the level of detail that you look at in terms of the usage of plans and whatnot. I wonder in terms of to what extent are they actually looking at some of the utilization data, and that would be in the white paper type of literature or white literature, rather than actually in the research literature. But that may actually also drive some of the questions that you know, where the gaps are, that could be articulated in terms of what your research would actually help them.
Thank you, Will. Yeah, I think actually some of the best literature on this is in ASPE reports and in MedPAC reports. I see very little in the published literature. I think you're absolutely right. And I think reviewing those and making sure I'm like emphasizing what people are most interested at CMS makes a lot of sense.
So in the chat, just so you see it before we close out, Bevan had a comment around, if you looked at some of the regional and market factors, could there be differences in some of the demographics or socio-demographics just based on where those companies are targeting and advertising and that kind of stuff? And then Harriet commented around advanced dementia, and if you're going to be able to kind of distinguish that within those R01 aims.
Yeah, so yeah, I think to Bevan's point, that is a great question in terms of where plans are offered, that is available. in terms of advertisement, you can't see that, but you could certainly look at growth, and where regions where plans are aggressively growing, which my guess is highly correlated to where they're, pouring money into advertising. So I think that, yeah, that you could definitely do would be really interesting. And then for Harriet's question, right, so the incident dementia, as I said, we're doing some more validation work to get our heads around what incident claims-based dementia is, which my guess is different than incident clinical dementia. Advanced dementia is tricky in claims data. Like, fortunately for a lot of these populations, if they're using home health, which many people do with dementia, actually the majority of a home health stay or a nursing facility stay, you have better indicators from MDS and OASIS on sort of clinical factors. But yeah, otherwise, we can look at healthcare use, but not necessarily other like clinical advanced dementia as we wish we could for many populations. I think that's a big caveat for all of this with the claims work.
All right, well, we're a couple minutes after, so thanks so much for sharing this, Claire. This is kind of exactly the type of thing we want to do, is be able to kind of brainstorm and throw it all out there and try to fit it in. So we're welcome to find you another slot closer to October. If that would be helpful, we can certainly do that.
That would be great. Thank you.
Thanks.
And thank you for your patience with this like messy slew of MA data and ideas. I know it was a lot.
All right, and anyone, please follow up with Claire with other thoughts or comments. Great, we'll see you all in 2 weeks. Thanks, guys. Bye.